Good morning, good afternoon, or good evening, depending on where you're listening. Welcome back to AI and the Future of Work. Thanks again for making this one of the most downloaded podcasts about the future of work. If you enjoy what we do, please like, comment, and share in your favorite podcast app. And we'll keep sharing great conversations like the one we've got today. I'm your host, Dan Turchin, advisor at Insight Finder, the system of intelligence for IT operations, and CEO of PeopleRain, the AI platform for IT and HR employee service. Today, we're picking up on a theme we discussed a few weeks back with Paddy Padmanabhan from Demo Consulting. We started a discussion about the future of healthcare for employees, but also about how your data is being used to make automated decisions about your health, and what you should know about how AI technology is disintermediating hospitals and insurance providers. Marpai Health is pioneering a new way for employees to get better care with, call it, less friction by guiding you through the complexities of your existing health benefits plan. We've all felt anxious over not knowing what's best, say, in-network versus out-of-network, HMO versus PPO, high deductible versus low deductible. It's super confusing. Maybe all we need is a little concierge service provided by AI. We're joined today by Edmundo Gonzalez, co-founder and CEO of Marpai Health, the company behind the app that helps you understand your health benefits. Edmundo founded Marpai in April of 2019 and has since launched the app, grown the team, and taken the company public on the NASDAQ last October. As you and I know from trying to understand our own benefit statements, Edmundo's work is just getting started. Before Marpai, Edmundo was an investor and operator at companies like Freight Hub, 340B Technologies, and Chalkable in the edtech space, which was acquired by PowerSchool. Without further ado, it is my pleasure to welcome Edmundo to the podcast. Edmundo, let's kick things off by having you share a little bit more about your background and how you got into this space.
Sure. Well, it's a pleasure to be here with you, Dan. It's going to be a great conversation. I can already sense it. I got into this space because I have been in basically the tech space all of my professional life, investing in companies and also building them as a founder and entrepreneur. And I just saw such a huge opportunity to make people's life better in a very transformative way. And let me explain. A lot of how we consume our healthcare, especially in the United States, which is a little different, as you may know, than basically all other advanced economies. A lot of that has to do with the health plan, meaning who is covering us, what kind of benefits are we getting from that plan. So I started this company really with a very simple mission. I said, hey, what if we could predict who's going to be sick or who's going to have a high cost event way before it happens? With that information, can we actually help that person, that member of our plan, make some choices to potentially prevent that high cost event, or at least to better manage it? That's how it all started, and it's been quite a journey, as you said, in just a few years.
We've heard a variety of perspectives on what's broken about healthcare in the US, and something we haven't talked too much about is what's broken about the third-party administrator or TPA system. I imagine you might have some thoughts on that.
Yeah, well, first of all, for your listeners, so let me just define this. So you know that in healthcare, about half of us in America are getting our healthcare benefits from our job. These are the employer-sponsored health plans, right? Now, those come in two flavors. Companies can either buy insurance, so from companies like Blue Cross, from Aetna, Cigna, et cetera. These are huge, huge companies. Now, all of that is an insurance product, meaning your company is paying a fee per employee per month to have you insured. Now, there's another model, which about half of companies use, certainly companies that are above a few hundred employees. That's called self-insurance. Self-insurance really means that you as a company are paying for your employees' health care as they consume it. So there's no insurance per se. You're actually getting those bills, those medical claims, and then you're paying them. Now, think about it. What if you're a law firm and you have 300 employees? Well, you may be really good at practicing law, but you don't really know how to pay a medical claim. There's art and science to this. That's where we come in. We are what's called a third party administrator, or TPA. And what we do is essentially administer all of the healthcare benefits for self insured companies. We partner with them to essentially provide everything from that little card you carry in your wallet, which has, in our case, obviously the Marpai logo, but everything. We provide through partners, telehealth benefits, pharmacy benefits, everything that has to do with healthcare, we manage on behalf of our clients.
What is it that most employees at these organizations with self-funded healthcare plans don't understand about the process, and what do they respond to best when they are introduced to a more modern alternative like Marpai?
You know, in if done right, the healthcare benefit under self-insurance looks and feels pretty much like it would under full insurance. In other words, the employee and the employee's family would still have a plan with a deductible. They can still have, access obviously to most doctors or any doctor, depending on the plan. So the look and feel of that is pretty similar. Now, how are we really changing this for the benefit of employers and obviously for the benefit of employees? It really is about taking a look at a member's journey, that healthcare journey, as that member goes through life. Meaning, if that member is going to CVS to get the fifth script of a certain drug, for example, what our algorithms are doing is taking that little data point, which is happens every day, as we walk around, as we go about our business. We're taking that little data point, but comparing that with all of the medical claims that that member has, and also where does that member live? What's his age or her age? Who is that member? And we're comparing that to a huge research universe that we have built with tens and tens of millions of claims, millions and millions of people, essentially a universe that looks like society. And then our algos say, hey, well, this member that just got, again, that fifth script at CVS actually looks like these 10,000 people over here who ended up in the ER in 3 to 6 months. So we should intervene and see what's going on with that member. So that's the predictive power. This is how all of these algos really work. Now, what happens then? Prediction is not really worth much without action. So what we do is we have a team of care team, RNs essentially, that are looking at these predictions and then reaching out to the member and getting them to the right care. What does that mean? Well, the right care in many cases may mean a visit to your a primary care physician or internist. It may mean some labs, but it may that those are very simple, kind of low cost events for the member and for the plan. In many cases, it's free to the member. But that visit may put that member under a doctor's care now in a maintenance drug. And let's say that maintenance drug costs $50 to the plan. Maybe the copay to the member is $10. So that event may keep that member out of the ER in 6 months. That's what we do. That's what we do. We're closing the loop in gaps before those gaps become really problematic for the member. And obviously for the plan who is paying for all of this. Our strategy is really two-pronged. We want to get higher health outcomes, essentially healthier people. That directly translates to lower costs for our clients who are paying the bill. Essentially, they're remember, these are self-insured clients, so they're paying for all claims as they come.
It sounds so obvious to hear you describe it. And listeners of this show know that just about every week we talk about how data is being used to make better automated decisions across all industries, whether it's education or construction or defense or anything else. And yet the current process of how healthcare reimbursement decisions are made, at least to me, is fairly opaque. And although it just seems patently obvious that you use data to make these decisions, what's the current process and how could it be any different from what you just described?
Well, first of all, the data of accepting a claim or not accepting a claim, that is certainly part of what we do. And look, we are into this business because we want to provide great healthcare benefits. We want to make sure that we're doing this proactively. Dan, in our great country, we have what I call at least a sick care system. Meaning, if you're sick, we are the best in the world of treating that and expanding your lifespan and just getting you well. What we're not really good about is actual health care, meaning proactive health that keeps you from being sick. So we have used, first of all, accepted that that is reality, but we've used all of the data that a normal payer would have, and we have transformed that to be a proactive tool on behalf of our members. So we are not about rejecting claims. We want to get you to your primary care physician. We just launched a whole program on gaps in care. So if you're a female of a certain age, you should be getting your mammograms. If you're male of a certain age, you should have a colonoscopy. This saves lives. Now, does it increase a little bit the cost to the plan? Of course it does, but that's an investment in keeping you out of a hospital or having a very, very high cost event in the future. The thing is, a lot of us in America, and I include myself there, we haven't really been taught to take those preventative care measures. That's what we're doing. Now, we're doing it, of course, not only broadly speaking to keep everyone healthy. Of course, we're doing that. We're actually very focused on people that are on a journey to really end up with a high cost event in 3 months, 6 months, 12 months, essentially in the near term. Why are we doing that? Well, this is obviously very costly in terms of human health, first and foremost. And secondly, that is what's driving our healthcare costs. Our healthcare costs are higher than any industrialized country out there on a per capita basis because we're not as proactive as we should be. So we're targeting those very costly events first, while obviously our long-term goal is just transforming how we as a population approach health in terms of proactive measures to keep our health outcomes up.
So now is where the conversation gets a little bit complicated. So with with great power comes great responsibility. You're using people's data to build deep learning models to predict risk. To your point, we want to provide healthcare, not sick care. I think that's a nice way to say it. But the cost of a false negative, someone is at risk and you miss it, is great, as well as the cost of a false positive.
Yes.
You predict that someone is in grave danger, and in fact, they're not. Talk to us about how you're using data, how you build the deep learning models, and how do you mitigate the risk of false positives and false negatives?
You're hitting the nail on the head. Look, in the world of artificial intelligence, you really have two big metrics. I'm talking like big picture, and that's what's called precision and recall. Right? Let me deal with recall first. Recall is essentially your capture rate. Right? So let's say in a population of 10,000 employees and their families. that you had for certain, meaning that if you could tell exactly what that population was like, you had 200 people that were going to develop, they were on a journey for sure, going to develop a certain condition. Well, the model, meaning the AI that you develop to predict who those 200 are, that has to be measured on recall and precision. So recall is basically the rate of how many of those 200 you actually captured. Okay? Now, precision is the other side. Precision means, let's say that your model said, well, it's these 200. Well, how correct were you? Meaning, we're only 100 of the 200 actually developing this condition. That would mean your precision rate was 50%. Not very good, right? What I a kind of err on is recall. Recall meaning I want to capture as many of these cases as possible. This is a moral argument as well. And by the way, these two metrics fight with each other, right? So you can have very high recall and low precision and very high precision and low recall, right? It's a natural kind of tension when you're building these models. But our job here is to capture as much as possible. So then it gets to the other side. Well, you may have some false positives. Now, what's a false positive in our mind? Okay, so you went to the doctor, and thank goodness you actually didn't have this condition. But was that doctor's visit a waste of time? I don't think so, because they also captured your weight, your blood pressure, right? So the cost of the false positive for us is normally a quote unquote wasted primary care visit. I don't think it's a waste. I really don't. But that's how we're thinking about this. And look, being moral, right, in this space is quite important. So we could well make the decision to have almost perfect precision and then miss some. Essentially, our recall would be lower. I just don't think that's morally right, and we're not going to do it.
Hey, so to everyone listening, play that back a few times. That last couple minutes was it captures a lot about how AI-driven decision making works, and that does really well said, Edmundo. So, as a patient, I obviously want to benefit from models that have high precision and high recall, like you said. They're trade-offs, and as a patient, I benefit from better functioning, more accurate AI models. And yet, the conundrum is that I don't necessarily want to volunteer my data to benefit everyone else to improve these models. So you mentioned ethics. It kind of talk us through the ethics of you need a lot of data, and the data comes from patients.
Yes.
And how do you what's your pitch to patients whose data you're aggregating to feed the deep learning models that benefit everyone?
Look, it's such an important question, and I think we as a society are going to continue wrestling with this, meaning, do I benefit from the prediction, from the product essentially that's being offered to me, but am I giving up something, some privacy, something that is mine? And by the way, it is yours. If anyone tells you differently, you should know that the data are yours first and foremost, right? I think that's a natural tension that we will continue battling. I'm not sure we're completely there as a society in terms of having an answer to all of this. What I will share with you is that our research library of tens of millions of patient information, it's all mostly claims, by the way, that is anonymized. That I have actually purchased from states or gotten into partnership with states. So that data is never our client data. Our client data is live data, meaning it's data as that member is going to CVS or is going to the doctor for the fifth time in the short span of time. But and that data, by the way, is only used to predict, what that member is experiencing or not experiencing. So there's a very different world here, and it's very important for listeners to understand. AI is a technology. It's not a product, okay? And that technology needs to be trained. It has to learn just like our human brain learns. So it's important that it learns on a huge amount of data, but that data doesn't have to be yours. That data is normally purchased in an anonymized way, so I can tell someone is male, that someone potentially has this weight or that weight, but all of that world is in our research data universe, and that's certainly not the data that you're sharing with us on a live basis.
But so let's say, hypothetically speaking, the source of your data, let's say states, like you mentioned, uh, their process for aggregating the data, I get that it's anonymized, but let's say that those who volunteer their data to the state may not be representative of the distribution of, let's say, ethnicities, races, genders across the whole population. So you're potentially purchasing data and making decisions, training deep learning models based on it, that inherently has some bias in it. How do you defend against that?
First and foremost, the fight against bias is realizing that bias is a thing, right? So you can't really solve a problem if you don't acknowledge it's a problem. The way you actually fight that, if you will, is first and foremost having huge data sets. So you can't have a representative sample or call that representative of America and have tens of thousands. You really need millions. They have to be diverse. And then you check. So is the ethnic composition, for example, of your data set representative of America? Or if you're not targeting America, let's say that your whole market was Florida, for example. Well, does it look like Florida in terms of age, race, everything, access to food, the income inequality? Remember that the drivers of health are varied. This is a complex world, and that's, you have to realize this, right? Your zip code matters in terms of your health outcomes. So, do you have all zip codes, or do you have zip codes that look like this zip code, right? You have to realize these items in order to make sure that your training data is valid and representative of the target population. In other words, you have to have apples and apples, not apples and oranges. And it's a constant item that one has to really be very careful of. We're very passionate about making our research universe look like the clients that we're serving across the country.
As a consumer, an employee, a patient who's impacted by the decisions made by these deep learning models, should I know when a decision was made based on AI? And depending on your response to that question, should I understand what inputs were used to make that decision? How much configurability or explainability should I expect as someone whose healthcare decisions are made based on AI?
Yeah. So let me actually separate here the items a bit, because I think your question has many nuances, and they're all important. So first and foremost, we're not really making decisions based on our deep learning model. What we're doing is identifying anomalies and identifying items that are not normal. And I say that, what does normal mean? It means that it's not what's expected. And what is expected? Well, again, a research universe of millions and millions of interactions, millions and millions of healthcare journeys, right? So this journey, if it comes to an alert driven by our algos, is kind of atypical. So that's first and foremost. But then what happens? Well, we're not saying, okay, this person is for certain going to get X, Y, and Z. We're saying, let's get that journey looked at by a clinician. So our care team immediately looks at this and intervenes, meaning interacts with that member, with that patient, and gets them to the right care. Ultimately, we need to have the power of healthcare decision making in the hands of doctors. Our tools are essentially moving you to that doctor, to the right care, to the high quality physician, right? This is all data that we're also looking at in terms of quality. That's a whole other item as well. So it's not really a decision making as much as alerting the member via a care professional that something has gone kind of off normal. That's really the bottom line here. In the future, should you be aware that this prediction was made, at least in part, by an AI? I think so. I think so. I think, by the way, one would be surprised to understand how much of our daily movements, whether it's shopping or selection of what you buy in the grocery store, how much of that is actually driven by data and advanced analytics like AI, not only AI, but like AI. And yes, this would be one as well. But these are helpful tools to get you to the right care. It's not the care. Let me just separate that and be very clear. Your listeners should know deep learning is not going to prescribe medicine to you. It's not going to give you an MRI or prescribe an MRI. It's really telling the care team, hey, take a look at this patient because there may be some things that are going kind of off track.
So in all data-driven fields, a common obvious hypothesis is that the one with the most data wins. And in healthcare, we've seen pretty aggressive moves into the space from big tech, from Apple and Amazon and Microsoft, even Facebook, because they own the data. What's your counter argument? How can Marpai win when you're competing with these massive incumbents that own all this data?
You know, they first of all, big tech does have a massive amount of data, but um, we want the right data. Like, do they have health records? Not really. Do they have a medical claim? Certainly not. Right. So you have to also focus on what's right, what's right in terms of data, what is going to give you accurate models that can change people's health trajectory. It's really, I guess there could be some items that have to do with your, Instagram patterns and consumption of Instagram, but really, it's different data. And I think that's what's so fascinating and so interesting here. I mean, think about it. All of our predictions here are actually not made with health records. It sounds counterintuitive, but we're not using health records. That's the challenge, right? We love hard problems. So we, as a healthcare payer, as an administrator of healthcare benefits, we have medical claims. We obviously have population statistics like where you live, how old you are, etc. Are you male, female? But we're making a lot of our predictions are based on claims, but it's not health records, right? So there's many ways to get at actionable data and actionable insights. And I don't believe the issue of, ever more is best. Certainly they have their businesses and everything, but it's really the right data. Are you creating a universe of unbiased data that looks like society? And then does that data have enough signals that your algorithms can then train and learn from, and then apply to me as I go to CVS or as I go to my doctor for the fifth time and generate the same medical claim? That's a big question. We're doing it, by the way, but the industry at large, not so much.
So the biggest insurance companies and the biggest third-party administrators do own a lot of the claims data. We know certainly in the technology field, we know that they tend to be tech laggards, not tech leaders. And that's what gives companies like Marpai an opportunity to disrupt them. But given that, they obviously eye the same opportunity to digitize and monetize their data and build better models. What has their response been to Marpai's entrance into the market?
You know, so far, a lot of our growth has been actually from groups that are moving from those fully insured behemoths to self-insurance just because they can't afford it anymore. Meaning, uh, companies want to provide great healthcare. It's part of the overall benefit, just like your salary, right? I mean, it's part of what you get by being part of this company, being an employee in company X, Y, or Z. But the cost has just been completely prohibitive. So far, they have still been the sleepy giants. I don't expect that to continue, right? So far it has been, I wouldn't say easy. Nothing's ever easy, but we have really operated and grown and continue to grow without much interference. I will tell you that we even with two of the largest bukas, essentially the big players, we actually rent their entire national network. So we're able to give our members access to all of these national networks, which is great because that access is the key. We want our members to be able to access any doctor they want. Our networks cover 90% plus of all doctors and facilities in America, right? So I think they have found ways to, still monetize even when they're not the primary provider of the healthcare benefit.
So polish your crystal ball. Let's say in 10 years, we're having a version of this conversation and Marpai is wildly successful. How is life different? How is healthcare different for me as as an employee?
Well, I think first and foremost, health has become proactive, right? So health is not something that happens to you. Health is something you drive. And that is it sounds so simple. It's completely hard to do. All of that movement has much more to do with behavioral economics and psychology than any AI, right? But I think our responsibility as payers of the future is really to get products that are easy to use, easy to understand, and that deliver tangible value to members, meaning, oh, this tool actually reminded me that I hadn't had my colonoscopy, or if you're female, I hadn't had my mammogram in its time. And then something is found and a life is saved. That is remarkable, in the world, but it's also remarkable for that member, for that member's family, and then that spreads. That is the news, right, around the cooler, even if it's a virtual water cooler these days with us working from home. But that is what we do, and I think that is the change that will drive members to really use some of this. Essentially, not just take their healthcare benefit for granted and say, okay, when I'm sick, I have my little card and I go to the doctor. But really, how are you looking at this proactively? How are you looking at the measures that impact your likelihood to have diabetes in the next, 3, 4 years? All of that has to do with education, and the health plan must be at the center of this. So that's part of the transformation we're doing. It's a very, very exciting time for us, for our members, obviously, and for our employer group clients. But yeah, I see the future. The future is proactive.
Edmundo, we're about out of time, but I'm not letting you off the hot seat without answering one last question for me. So we've been talking mostly about the benefits administration process, but I want your perspective on the future of medicine. So through the last couple of years in the pandemic, obviously there's been a massive shift toward telemedicine, but also the advent of wearables, monitors, sensors. Is there a future in which instead of me having to go to the hospital to get some kind of medicine or healthcare service delivered, will it ever come to me? Is there ever a time when that traditional notion of me having to do a doctor's visit and sit in the waiting room and that sort of thing, could that very notion of how we get healthcare delivered ever be disrupted?
You bet it is, and it's already being disrupted in many cases where there's home care, especially for seniors or for people that are experiencing long-term care at home. The cost of that delivery is a fraction of the current model. It's where we need to go. And all of these wearables and things, think of this, although that segment looks mature, it's just starting. It really is just starting. And I think, members of health plans, I include myself here, have a role to play in the development of this space. Some of it is scary because, of course, it's collecting data. It may be syncing it with your iPhone, but the benefits of that, I think, in the years to come, are going to so outweigh any concerns on data that I my personal prediction is that I think the majority of members will opt in to some sharing just because the benefit is so great. So no, I do believe that the future is personalized and the future is certainly more at home, but don't confuse the machine, meaning the little device, with the healthcare provider. This is all tools. A stethoscope, old school stethoscope, it's basically a tool. Your watch can become that stethoscope. It's just remote. You have it live. That's really the future. I think that's the way to think about it. These are tools that are monitoring you for your benefit. You call the shots. You say what you want to monitor and what you're worried about in order to take care of yourself, and in order finally to move to a real healthcare system versus sick care system.
Edmundo, this has been fantastic. I've really enjoyed it. We're just scratching the surface. So much more to discuss. If I could invite you back maybe another time, we'll continue the discussion. How would that be?
It would be my great pleasure. Thank you so much for having me. I enjoyed it.
You bet. Anything else our audience should know about Marpai or where they can learn more?
No, certainly one can learn more at www.marpaihealth.com, and Marpai is MARPAI health.com. Thanks so much, Dan.
Fantastic. Great having you here. And that's a wrap for this week. I'm your host, Dan Turchin of AI and the Future of Work. We will be back next week with another fascinating guest.